Today, I have the pleasure of discussing with you the perioperative risk assessment determination in pediatric patients, the tools that we have available to us to determine that, and the importance of the ASA physical status classification in looking at pediatric patients. Interestingly enough, it is important to really understand why we even care about risk stratification. Well, certainly the length of stay for our surgical patients is determined by variations in risk. The resource allocation that is required for each patient may be affected by the different risk and comorbidities. To set clinician and family expectations with the timing of surgical procedures, very important to understand the risks. And if your institution is actually negotiating bundled payment and the risk is not assessed properly and the comorbidities and complexity of each patient are not assessed, the alignment of cost and revenue may not be aligned. And certainly if we can assess risks preoperatively, optimize those, decrease morbidity, we can improve postoperative outcomes and prevent readmission. So there are lots of commercially available risk calculators on the market. You can see this is one, there are many, but really they're not specific and related to pediatric patients. So the one that is most commonly used is the American College of Surgeons Pediatric Surgical Risk Calculator. And this is an online tool that's readily available. It looks at 18 different risk factors to determine 9 postoperative outcomes. And what you can see here on the right is that there is an attempt here to quantify some system-based comorbidities. But very important is that the ASA classification is an integral part of this tool, and a correct ASA classification really informs the accuracy of the tool and the risk prediction. So to further elaborate on that and to try and incorporate comorbidities into surgical risk, a system of intrinsic surgical risk has been developed, and it was developed by looking at almost 400,000 cases encompassing 659, almost 700 CPT codes, looking at the 30-day post-op mortality in an attempt to determine what part comorbidities played in risk prediction for different patient populations. And these patients were divided into 4 quartiles so that the intrinsic surgical risk can be in quartile 1, 2, 3, or 4. And you see here again, an accurate ASA physical status determination is an integral part of this calculation as well. And to further refine this, we actually developed what we call our RAMP score, which is a risk assessment of morbidity in pediatric patients undergoing non-cardiac surgery from Boston Children's Hospital. And part of the variables were the age, whether the procedure was urgent or not, the criticality of the patient's illness, the intrinsic surgical risk quartile that we just explained, the chronic complexity indicator, and the specific chronic complexity indicators, but also very important was the ASA physical status. And actually what we learned is the highest risk was seen in children under 5 years of age, procedures that were urgent, those who had an intrinsic surgical risk quartile of 3 or 4, and they had either 4 or more chronic condition indicators or 2 or more of the significant chronic condition indicators, and you'll see the definition of those below. So interestingly enough, on a completely unrelated project, we tried to look at ASA classification against the chronic condition indicators and the Freud-Nurse complex chronic conditions. And as every anesthesiologist knows, an ASA1 patient is a patient that doesn't have any significant comorbidities and is relatively healthy. And when we did this card analysis, we were very surprised to see that in our hospital, 45% of ASA1 patients had chronic conditions. And of that 45%, 17% had multiple chronic conditions. So as you can see, obviously, these were not ASA1 patients. And similarly for ASA2 patients, 50% of them had multiple chronic conditions. And as you recall, ASA2 patients should have one systemic disease or that's under good control. So we really looked at this to say, what is going on here and why is it that we are really improperly and underclassifying our pediatric patients? And if we go back to the ASA physical status classification, we want to remember that it doesn't predict perioperative risk, and it certainly is not applicable to pediatric patients. So pediatric practitioners have to infer what the definitions would be for that class of patients from the standard ASA classification. So we propose this question. Does the current American Society of Anesthesiologists physical status classification represent the chronic disease burden in children undergoing general anesthesia? And if you look, and this is from the ASA definitions in 2014, if you look at these definitions, an ASA1 patient is a normal, healthy patient, but the example is a healthy, non-smoking patient who has minimal alcohol use. And I would really hope that most of our pediatric patients do not fall into that category. ASA2 patients have mild disease, but they are, the examples are whether you are a smoker, only a social alcohol drinker, whether you're pregnant, obese, whether you have mild lung disease, et cetera. And, you go on down this list, and you can see that most of this, other than ASA3s, where they include in premature infants under 60 weeks post-conceptual age, the classification really is defined by adult parameters. So it's not a stretch to really understand that there is not a lot of agreement, direction, or information for pediatric practitioners to actually determine what an appropriate ASA physical status classification would be immediately preoperatively for our pediatric patients. So we said, well, if we were going to create examples for pediatric patients, what would they be? So we took a group of pediatric anesthesiologists here at Boston Children's, and we came up with really just back of the envelope, what would the kinds of things, what are the kinds of comorbidities and diseases and organ system dysfunction would we include? And what we say here is our ASA1s are a healthy, normal BMI for age, no chronic disease. But then when you get to ASA2, we define this as maybe corrected congenital heart disease, well-controlled dysrhythmias, well-controlled asthma seizures, abnormal BMI. ASA3s would include chronic renal failure, epilepsy, muscular dystrophy, cystic fibrosis, asthma, et cetera. So these are the kinds of diseases that we routinely see in our pediatric perioperative patients, and give us a little more specific direction when trying to define the ASA physical status classification. So what we then went on to do was we took 120 cases that we had already completed where the ASA classification had been documented by our faculty based on the standard ASA classification definitions. We divided them up so that everybody got 10 cases. We gave them our proposed pediatric definitions, and we asked them to review the cases and score the patients using the new pediatric definitions. And interestingly enough, you can see here in the top that when ASA1 patients that were classified using the standard definitions were reclassified using the pediatric definitions, you can see here that about a little bit more than 40% of the ones went up to 2s, and about 38% of ASA2s were recategorized to ASA3, et cetera. So it really was our conclusion that this would really be something that would be of value. So using those that group of pediatric anesthesiologists and a bit of a Delphi method, we went back and further refined the definitions that we had come up with based on the input from the providers who had reviewed the cases. And they wanted some additional detail and specificity with these definitions. So we modified them and we went ahead and we published them. And our hypothesis here was that a pediatric focused ASA physical status stratification would be of clinical value. But we realized that our work was just all based in one single institution. And maybe we at Children's Hospital were just not very good at determining ASA physical status classification. So we actually embarked on a multi-center study that included both national and international providers. So we did a prospective mixed method study of 197 pediatric anesthesiologists from 13 hospitals in the United States, Europe, and Australia. And we surveyed them twice in May and July of 2019. The participants assigned ASA physical status scores for 15 pediatric cases, and each provider received the same 15 cases with a heterogeneous mix of acute and chronic health conditions undergoing a variety of surgical and related procedures. And the most updated recent pediatric adapted definitions were provided, and we asked them to review these cases using the ASA physical status definitions that we had defined for pediatric patients. And this is an example of the kind of case that we sent them. And this is a 22-kilo 4-year-old presenting for brain MRI under general anesthesia. She has poorly controlled epilepsy with seizures increasing in frequency over the last few months, accompanied by associated headaches, and she takes sodium valproate daily. And the chart underneath is the aggregated response from all of the 197 pediatric anesthesiologists as they rate this particular patient using the pediatric definitions. And what I will show you here is basically the aggregated information that we sent out with the results on each little graph here for each clinical scenario. And what we also did, which was interesting, is look at the interclass correlation coefficient within each institution. And you can see that institution A, for instance, had very little variability within their providers, where I had great variability within their own institution. So this is such a subjective categorization, even within individual institutions. And what we did is sort of a fun little offshoot was we did a word cloud of all of the different responses that came from that multi-institutional study to see what were the kinds of things that providers were really concerned about. And interestingly enough, they wanted to know about what do you do with patients who had a gastrostomy tube? What do you do about variations in obesity going from mild to morbid obesity? What about the BMI? What about the chronic persistent conditions? What about the acute conditions, et cetera? So again, we took all of that information and further modified the definitions that we were proposing. And you can see here on the right the suggested additions based on the qualitative data results coming from that multi-institutional study. So we further refined the elements of those definitions. And then, of course, we went to all of the organizations and leadership of the pediatric anesthesia community to vet this. So the most recent updated definitions were provided to the leadership of the Society for Pediatric Anesthesia, who approved them, the American Academy of Pediatrics section on anesthesia, who also approved them, and the Committee on Pediatric Anesthesia within the ASA, before we actually proposed that these would be officially adopted. And what you can see now, as of 2020, the most updated guidelines from the ASA, you can see here. And there are very specific official pediatric examples that providers can use when assessing pediatric patients preoperatively. And we are really delighted that this has been adopted. And it's really important that this be shared, learned, socialized, because if you go back to all of the tools that I showed you for risk stratification, an accurate ASA physical status classification is important. And the more specific and accurate we can be in our classification of patients, the more useful those tools will be. So what did we do with this information? Well, it was interesting because we said, well, gee, now we have these ASA classifications for pediatrics. Is there any way we can incorporate this into our anesthesia information systems and into our electronic medical record? So here at Boston Children's, we are a Cerner shop. We have a Cerner platform. But what we have as part of our pre-anesthetic evaluation is one module called the pre-induction review, and that is filled out by the faculty anesthesiologist prior to going into the operating room. And you can see here that documentation of the ASA level is part of what is required preoperatively. But what we have done in addition is embedded a module into our anesthesia information system that actually invokes a machine learning artificial intelligence prediction of length of stay, which is patient specific, and it's based on the ASA classification. So what it will do is it will document all of the chronic risk factors. It will suggest the ASA classification based on the pediatric definitions. And if the provider forgets what those are, one would hover over the number and the definitions will pop up. And then the provider will actually go back, see what their preoperative ASA from the pre-anesthetic evaluation form was, look at the predicted ASA classification from the model, and then go ahead and input what the final would be. The final is always determined by the clinician, but it is information to help with decision management, bring to light some of the comorbidities that the provider might not be aware of. In this example here, the anesthesiologist classified the patient as a 3. The predictor said 2.2. The anesthesiologist maintained the patient at 3. And sometimes it just goes the other way. But it is a really nice way of us to almost force the utilization of the pediatric definitions, but also use predictive analytics in trying to have objective information about what ASA classification would be, and taking that together with the clinical information that the faculty would have, I think gives a very accurate and comprehensive way to make this assignment. And then what we did was went ahead and looked at, did we make a difference? And so our objective here wasn't so much to use our new tool to change the decision, but to provide information. And it changed in some cases, but our point was, is if you're using the correct ASA physical classification, and if you're cognizant of the comorbidities, you will make the right choice the first time. But you can see here that in about 12% of cases where the preoperative ASA was determined to be 1, once the predictor was run, 12% of the time, the providers actually upgraded the patient to ASA 2. The same with ASA 2, about 6% of the time, clinicians upgraded the patient to a 3. Interestingly enough, 6% of the time they downgraded them down to a 1. But it is interesting, since this is such a subjective measure, to see how clinicians use this information. And you can see here that if you look at the number of cases, you can see that for ASA 1s, a large percentage remained the same, but 89 were upgraded. For ASA 2s, 110 were upgraded, 122 were downgraded. And as we continue to use this, we'll do this kind of analysis to see how patients are upgraded or downgraded. But our hope is that once people become more familiar with the pediatric specific definitions, they will be accurate the first time around in their prediction. And so this is always something that we have to continue to ponder, continue to think about, continue to refine moving forward. And I hope it's been informative for all of you. I hope you'll go forward and learn the pediatric definitions so that when you are considering your pediatric perioperative patients, you'll have this as an additional tool. So thank you for your attention.